To give the next talk, and probably if we have time, we will have the discussion and cases after. Dr. Sugaranjini is a consultant at Giridhara Institute, and she's going to talk on Tenonplasty, when and how to do it. Dr. J.K. Reddy is not available, it seems, so we'll have the last talk.
A very good afternoon to one and all.
Dr. J.K. Reddy is not there.
Sir will come. Yes, inform sir will come.
Go to the next talk now. Okay, whoever is there. If we have time, we'll have the last talk.
At the outset, I would like to thank Dr. Vinay Pillai for including me in this IC. So when you see a patient like this in your ophthalmic setup, and if the referral center is at a distance, it can make you skip a heartbeat. And a tenonplasty in such cases can really save the situation and can be done by any ophthalmic surgeon. So among the array of options that we have for sealing these corneal perforations, Tenon patch graft scores over the others in many ways. These are the options that we can use in a case of a corneal perforation, that is a tissue adhesive or a multilayer amniotic membrane graft, a Tenon's patch graft, a corneal patch graft, or a TPK. But a Tenon's patch graft scores because it does not induce any vascularization. It comes at no additional cost to the patient. You don't depend on an eye bank in these cases, and it gives a good volume replacement, and there is practically no risk of rejection. And it's an easy surgery with a very less learning curve and can be done by anybody. So this is a follow-up of a patient with Tenon's patch graft, which shows that the Tenon's graft gets incorporated into the cornea very well, and it is a good option for these cases. But as in any particular case, a case selection is very important. One needs to remember that a Tenon's patch graft would not work in a case of a corneal perforation due to acute infections. So it is usually preferred in patients who have an underlying autoimmune or neuropathic pathology, and if the size of the perforation is small with a volume deficit, and if you also have a cicatrizing conjunctivitis in place, and if you don't want vascularization, Tenon's patch graft is a good option. So what does this exactly mean? As we can see from the top row of all the images, a Tenon's patch graft would work in all the top row of images where there is it looks like a sterile melt and it is small in size, but it would definitely not work in the bottom row where you can see an element of infection in place. So you would avoid Tenon's patch graft in such patients. The steps of the surgery I'll be explaining through the video. Can we please? So it is simple. It's a simple surgery where after inducing a chemosis on the superior, you resect the conjunctiva and extract the Tenon's graft underneath, like how sir mentioned in a pterygium, you would avoid including a Tenon's. In this case, you would actually extract a piece of the Tenon's. After drying the surface, and if you want to seal it better, you could use you'd use a fibrin glue, and you can trim it to the size needed. And once you have fixed it with the fibrin glue, you can take overlay sutures, which are more in a box shape, to just hold the tissue in this place. One must remember that this does not create a watertight anterior chamber. And while reforming an anterior chamber, make sure you don't form it to the full extent, and probably leaving it back as a soft globe would be the best thing to do. So now we can see that the air bubble is complete and the AC has been formed. So there are some modifications in the technique that I showed, which has been discussed in literature. So one is the amniotic membrane graft can be placed over the Tenon's, or a tissue adhesive like a cyanoacrylate glue can be placed over, or a tuck-in Tenon's patch graft can be done. So let's look at these procedures. So in case of an amniotic membrane graft, as I said, a Tenon's patch graft doesn't give us a complete watertight anterior chamber. So by placing an amniotic membrane graft, you would be providing an additional tectonic support, and you could get a watertight closure. This also helps in epithelialization, which happens in 2 weeks, gives a good tensile strength, and this patch graft becomes translucent with time. So it is preferred in a central corneal perforation where you would want a good visual outcome as well. While using a tissue adhesive, this is published by the CMC Vellore group, where the pink area is actually the Tenon's graft, and they've used the cyanoacrylate group, which are the green drops, to hold the Tenon's graft in place. Probably the only disadvantage in this is that, as we know, a tissue adhesive would induce vascularization. So preferably you would use this for a peripheral lesion, and where vascularization will not damage the visual outcome. So this is a video of a use of cyanoacrylate glue with tenons. So the most important step is this, where you have to debride all the necrotic tissue from the area of the perforation, remove the pseudocornea, and the epithelium needs to be debrided on a large area, because this is what is going to hold the cyanoacrylate glue in place. And the steps of the retrieving the Tenon's patch graft has been already shown in the previous video. And once you have sized the graft enough, you plug the corneal perforation with the Tenon's graft. And once you've done that, you simply apply the cyanoacrylate glue over the Tenon's graft, and this will give a double support. And here, as you can see, it's a peripheral lesion, and even if vascularization is induced, it would not affect the visual outcome in this patient. So the last modification is a tuck-in Tenon patch graft. So just like how you have a tuck-in PK, here the Tenon's graft can be tucked into the corneal perforation by creating a lamellar pocket all around. So what are the advantages of this? This is a better watertight sealing, and this is a sutureless, you can also do it sutureless. And in a case of using an cyanoacrylate glue, there are chances of adherent leukoma forming. But in this case, series published by the Ames group, they have reported lesser adherent leukoma and better corneal transplant outcomes post this procedure. So this is a video showing the tuck-in tenonplasty. Quickly moving on. The tenons is harvested. So this is the important step, where you create soft lamellar pockets around the corneal perforation. And once you've done that, you just size the Tenon's graft enough, trim it, and then you can use probably an iris repositor to just tuck it into those lamellar pockets that you have created all around. And once you tucked it in, then you can take probably sutures all around, like how you would take a PK sutures. Make sure you don't pull them too tight, then the graft will get dislodged. And after this, you can probably even put an overlay of the box sutures that were shown in the first surgery, as it's being done here. So tenonplasty does give a great outcome eventually, and adherent leukoma is the most common complication seen with it, and which is not very harmful. It does give a good anatomical outcome, a good tensile strength. Visual rehabilitation is good with rigid contact lens, and the grafts done after this do fare better. They are not without complication, as I've mentioned. It does cause shallowing of the anterior chamber. The graft can retract and displace. If you see a shallow anterior chamber post the procedure, always observe for 7 to 10 days before you reform it, and it can undergo such things can happen, like where there is a hemorrhage in the Tenon's graft, and if there is an ectasia of the graft, just use a simple cautery to reduce the ectasia. It can melt. If you're seeing a melt, put a Tenon's graft and use a cyanoacrylate glue. So to summarize, it is the best procedure when you don't have a backup of an eye bank. It can seal small sized corneal perforations well. It gives a good tectonic support and a stable ocular surface. It does not cause any vascularization, and it gives good results if you take the patient up for optical PK later. Thank you so much.
Thank you. Thank you, Sugaranjini. May I know what time we have now left?